To all the respected teachers and my colleagues. Today we'll be discussing a case of an 8-year-old male child born by non-consanguineous marriage, came to the OPD with complaint of not growing well since 2 years, increasing pallor and easy fatigability since 1 year, and decreased appetite since 7 to 8 months. His parents complained that the child's weight and height was not improving since past 2 years, and his physical growth was less when compared to the peers of same age group. They also noted pallor, which has gradually increased over a period of 1 year. The child takes less interest in playing and gets easily tired on exertion. For these complaints, they visited physicians and took multivitamins and hematinics, but there was no improvement noted. The child's diet has also gradually reduced from 3 rotis to 1 roti. There was no history of the following complaints. No history of pica, chronic drug intake, perianal itching, previous blood transfusion, no history of any abdominal distension, loose motion, pain in abdomen, constipation, yellowish discoloration of eyes or urine, blood in urine or stools, and there was no history of bone pain, bleeding or rashes over the body. Past history, the child was admitted 4 years back with a complaint of fever, cough and respiratory distress, and he was clinically diagnosed as pulmonary tuberculosis on the basis of non-resolving pneumonia, for which he took a complete course of anti-tubercular treatment for 6 months. Birth history, antenatal history, mother was anemic and 1 unit of blood was transfused during her 3rd trimesters, and the rest 2 trimesters were uneventful. Baby was born by normal vaginal delivery, and it was a term delivery at 39 weeks. Baby cried immediately after birth and his birth weight was 2.9 kgs. Baby was shifted to mother's side after the birth, and there was no history of NICU stay during the neonatal period. The child was immunized for his age, and developmentally he was normal for his age. There was no significant family history. He has an elder sister who has no similar illness. He is a vegetarian by diet. His calorie intake is 1000 kilocalories per day with a deficit of 700 kilocalories per day. His protein intake was 25 grams per day with a deficit of 5 grams per day. And according to the modified Kuppuswamy socio-economic status scale, the child belongs to an upper middle class family. So to summarize this case till now, we have an 8-year-old male child who has a suboptimal physical growth, and he complained of gradually increasing pallor and easy fatigability on exertion, who did not respond to the hematinics along with a decreased appetite. He also has calorie and protein deficit and the past history of pulmonary tuberculosis. So now I would like to ask any of the residents would like to answer the probable diagnosis. Yes, it can be one of the differentials. Why would you say hypothyroidism? Okay.
So any other possibilities? Any bright young pediatric student or medicine student?
I think in such cases, also, when anemia is involved, you should get the peripheral blood analysis before asking the questions. Because it is so wide. Think of anemia is such a wide thing. It's iron deficiency or chronic disease or some hemolytic disease or genetic disease, so many things. So you have to come at least with a peripheral blood film or CBC. Then you ask the question, then might narrow down the things and solve.
Okay, so that was including the investigations. I'll be asking again after that.
तो बहुत बड़ा हो जाता है, पूरा किताब हो जाती है.
So now we have a child who is anemic with growth retardation, who did not respond to the hematinics. The first possibility kept was of protein energy malnutrition, as the child has decreased appetite along with the protein and calorie deficit. Next, as rightly said, it can be due to nutritional deficiency anemia, which can be because of iron, vitamin B12 or folic acid deficiency. It can be an anemia due to the decreased production of erythrocytes, for example in aplastic anemia. Or there can be some endocrine causes, for example in hypothyroidism. There can be chronic infections, for example tuberculosis, as the child already has a past history of tuberculosis, or it can be due to cytomegalovirus infection or Epstein-Barr virus infection. It can be because of some chronic disease, for example in kidney disease, liver disease, autoimmune causes, or in malignancies. It can be anemia due to the destruction of RBCs, for example in hemolytic anemia, and unlikely in malabsorption. One of the diagnoses was of malabsorption syndrome. We further examined the child. The child was conscious, well oriented to time, place and person, poorly built and poorly nourished, as his weight was 17 kgs, which was expected to be 24 to 29 kgs as per his age. His height was 116 centimeters, which was expected to be 124 to 130 centimeters as per his age. Head circumference was 49 centimeters and body mass index of 15.6 kg per meter square. On head-to-toe examination, we found that the child has a triangular face with a beak-shaped nose. There was pallor noted in the palpebral conjunctiva, and there was hyperpigmentation present around the lips and on the skin folds of the neck, as shown in the image. There was no lymphadenopathy. Hyperpigmentation was also present over the knuckles, and his palms and nail beds were pale. There were cafe au lait spot found at the back, which was measuring 2 by 1 centimeter, and one at the back of the thigh measuring around 3 by 2 centimeter, again shown in the image. His vitals were normal. He was afebrile and was maintaining saturation on room air. There was no any significant finding found on the systemic examination. His respiratory system examination, gastrointestinal system examination, cardiovascular and central nervous system examination was normal. So again, I would like to summarize this case. Along with the history that we have discussed previously, we found that the child has pallor along with the triangular face and beak-shaped nose. To summarize this case till now, along with the history that we have discussed previously, we have a child who has a triangular face along with a beak-shaped nose. There is pallor and there are skin manifestations like hyperpigmentation and cafe au lait spots. We further advised some investigations which reported hemoglobin of 5.2 grams per deciliters, which was low. His MCV, MCH and MCHC were within normal limits. That is, the child had normocytic normochromic anemia. He had neutropenia with a total leukocyte count of 2600 per microliter, along with thrombocytopenia with a platelet count of 56,000 per microliter. His peripheral blood film was suggestive of pancytopenia, as there was TLC and platelets reduced on the smear. DLC showed neutropenia and mainly lymphocytes. His reticulocyte count was 0.1%, which was again low. He had raised LDH, stool for occult blood and ovocyst was negative. His ASR was within normal range. Liver function test, renal function test and serum electrolytes were within normal range. His iron profile was normal. He had normal vitamin B12 and folic acid levels, and urine routine examination was also normal. We further advised some other investigations like high HPLC, which was normal. ANA profile was negative. Direct wound test was also negative. He tested negative for cytomegalovirus. His viral markers were negative. Chest diagram, 2D echo and USG was normal. So now I would like to come back to the audience. What can be the diagnosis after the investigation reports? Okay. Any other?
Okay, one is hypoplastic anemia. What else? A young boy with normocytic normochromic anemia and pancytopenia. B12 folic acid normal, stool normal, no abnormal peak of the HPLC.
I'm a hematologically lay person. Go back to your previous slide. So if it is pancytopenia, would you do, no, the next one, would you do all these, the last.
This one?
HPLC. Would you do all this or would something else should be done?
Sir, actually, to rule out all the causes, that we are expecting, that we have already listed in the differentials. So to rule out all those possibilities, we'll be doing these tests.
Isn't the bone marrow seems to be the culprit?
So we'll be going to the bone marrow as well, but before that we'll be confirming whether it's pancytopenia due to any other cause or not.
That's my question. Would you do bone marrow first, or would you do all these expensive investigations first?
Sir, we'll be confirming the pancytopenia and ruling out all the other causes, and then we'll be going towards the bone marrow.
ये investigation की slide पर और पीछे जाना है। No, back, all back. So what is the definition of anemia? When will you label the anemia in 8 years old child as the WHO?
So there is a physiological definition, which is a reduced capacity, reduced oxygen carrying capacity of the blood, which causes the tissue hypoxia. And there is another
What is the
definition.
physiological anemia and at what age of it appears?
Sir, age-wise, if we'll define, so basically it is defined as -2 standard deviation below the.
At what age there is a physiological anemia in a child?
Yes, sir.
What is the age of the child? 1 unit.
So basically,
What is the
infants.
difference between fetal hemoglobin and adult hemoglobin?
So basically, in infants, the hemoglobin is usually at the higher level, which is approximately 14 to 16 grams per deciliter. And as the child grows, the hemoglobin, the cutoff for the hemoglobin range reduces. And
So what is the half-life of fetal hemoglobin? What is the half-life of adult hemoglobin? Adult
so
RBC कब तक जिंदा रहती है?
adult RBCs की half life is 120 days.
और फिर fetal hemoglobin होता
So
है
fetal hemoglobin की is around 60 to 80 days. 80
तो
days.
किस ड्यूरेशन पे बच्चे को एनीमिया आना चाहिए नॉर्मल?
After 6 months, so 6 months तक तो.
8 to 10 weeks. You calculate according to the half life or average life of the RBCs. So fetal hemoglobin has to be replaced by the adult hemoglobin, isn't it? Then physiological anemia will happen. So that time you calculate what should be the reading that time. And at the first month of neonatal age, first month of life.
So first month of life पे HPF रहता है थोड़ा बहुत मतलब.
नहीं रहने मतलब hemoglobin कितना होगा?
Sir, first month of life पे 16 to 18 grams per deciliter.
एनीमिया कब लेवल करोगे?
And less than -2 standard deviation for his age.
-2 तो छोड़ो पर कट ऑफ वैल्यू बता रहे हो।
Less than sir 13 grams per 12 to 13 grams per deciliter.
Less than 11 ग्राम। और इस पे 8 years पे after 6 years.
Sir, adult criteria only, the less than 12 grams.
Go and read your books. You are not any consultant from the pediatrics department.
Hemoglobin is 600. WHO class 10 gram per deciliter, and newborn we define anemia less than 14 first 14 days of life.
We classify the anemia based out of the levels as mild, moderate, and severe. So severe is going to be less than 5. Between 6 to 9 is moderate, and 9 to 11 is mild.
So after the investigations, as there was no evidence of muscle wasting, edema or organomegaly, the possibility of protein energy malnutrition was ruled out. As the child tested negative for stool for occult blood and overcyst, and his TTG IgA was also negative, the possibility of malabsorption syndrome was also ruled out. As his thyroid profile was normal, the differential diagnosis of hypothyroidism was also unlikely. As his liver function test, renal function test, ANA profile was negative, and all the other function tests was normal. So possibility of chronic diseases was also ruled out. As he tested negative for cytomegalovirus infections, hepatitis virus infections, and there was no raise in CRP, so possibility of any chronic infections was also ruled out. As his DCT was normal and his reticulocyte count was low, possibility of hemolytic anemia was also unlikely. Because his iron profile and vitamin B12 profile was within normal range, he had normal folic acid levels. The possibility of nutritional deficiency anemia was also ruled out. So in the end, we were left with only the possibility of aplastic anemia, that is anemia due to the decreased production of erythrocytes. So what is the next investigation we would advise in this case? Yes, bone marrow aspiration and bone marrow biopsy. So I would like to request Dr. Kusha ma'am from the Department of Hematopathology to further oncopathology to further contribute.
Thank you, Dr. Shivani. Good morning, respected teachers and dear colleagues. I'll be discussing the hematological aspects of this case. So the complete blood count revealed anemia with a reduced hemoglobin of 5.2 gram per deciliter. There was leukopenia with a total leukocyte count of 2600 per microliter. And there was significant neutropenia with an absolute neutrophil count of 300 per microliter. There was thrombocytopenia, which was platelet count was reduced to 56,000 per microliter. So the above mentioned findings were suggestive of a picture of pancytopenia. Along with this, we were having a significantly reduced reticulocyte count, which was 0.1%. So the overall CBC picture was suggestive of a hypoproliferative marrow. We proceeded with the peripheral smear examination. So the image is that of a high power magnification of a GIMSA stained peripheral smear, wherein we can see the arrow points to the small mature lymphocyte, and we can see that the surrounding RBCs are of the same size as that of a nucleus of a small mature lymphocyte. So this is normocytic morphology. And all the RBCs are having preserved central 1/3 pallor. So this is normochromia within the red blood cells. Also, we noted there was leukopenia and significant neutropenia. So the predominant cell type which we were seeing on smear was a mature lymphocyte. The arrow above points to the reduced platelets which were seen on smear. There was no atypical or immature cells seen. So the impression which was given was pancytopenia with no atypical cells, and bone marrow studies were advised. So we proceeded with the bone marrow aspirate examination, and this is a scanner view of an MGG stained bone marrow aspirate smear, wherein we can see that the marrow particles have been replaced by fat and the hematopoietic elements are significantly reduced. So when we derive the cellularity of the marrow, we use a formula which is 100 minus age of the patient. So since our patient was 8 years of age, so his cellularity should have been around 80 to 90%. But here we can see that the marrow particle is showing significantly reduced cellularity, which was almost 15 to 20%. Also, the exact cellularity can be determined only on the bone marrow biopsy section. The next slide will be showing that. The other lineages, erythroid lineage was showing normoblastic reaction, myeloid and megakaryocytic lineages were suppressed. And on a higher magnification, we can see that there was collection of lymphocytes, plasma cells and histiocytes. There was no lymphoid aggregate or any atypical cell or granuloma seen. So the final impression which we derived was pancytopenia with hypocellular marrow. We proceeded with the bone marrow biopsy examination, and this is the scanner view of an HNE stain section which shows the bony trabeculae enclosing marrow spaces which are showing hypocellular marrow spaces. So as the arrow points out, the hematopoietic elements have been replaced by fat, and the overall cellularity was reduced to 15 to 20%. Also, the myeloid series and the megakaryocytic lineages were significantly suppressed. This is a higher magnification which was showing few megakaryocytes. There was no atypical cells or any lymphoid aggregate or granuloma noted. So on the basis of the CBC findings, the peripheral smear findings and the bone marrow biopsy studies, a final impression of hypocellular marrow showing no abnormal cells with the possibility of bone marrow failure was suggested. I would request Dr. Shivani to please proceed with the case.
Thank you, Dr. Kusha. So after the bone marrow aspiration and biopsy reports, we got the possibility of bone marrow failure syndromes. Now, bone marrow failure syndromes can be acquired or inherited in origin. Acquired can be due to some infections, or it can be due to intake of drugs and toxins. And the inherited ones are Fanconi anemia, Shockley-Diamond syndrome, dyskeratosis congenita, and there are some others. So in our case, as we have already tested, and most of the tests for the infections, viral infections, he was tested negative, and there was no history of any intake of drugs and toxin. So the possibility of acquired origin was unlikely, and we further proceeded with the diagnosis of inherited bone marrow failure syndrome.
No history of drug intake in the recent past.
In the recent past.
The child has received it.
So to come to the final diagnosis, we reviewed the characteristics of some of the inherited bone marrow failure syndrome. Shockley-Diamond syndrome is one of the inherited bone marrow failure syndrome, in which the patient usually presents with exocrine pancreatic insufficiency, growth retardation and skeletal defects. In our child, although the growth retardation was present, but the other two clinical features were absent, so the possibility of this syndrome was unlikely. Another one is dyskeratosis congenita, which is a triad of dysplastic nails, lacy reticular pigmentation of upper chest and neck, and oral leukoplakia, and none of these features were present in our case. So the possibility of dyskeratosis congenita was also ruled out. Next is Diamond-Blackfan anemia. It usually presents in early infancy, and there is pure erythroid aplasia, and the other two cell lineages are not affected. So the possibility of Diamond-Blackfan anemia was also unlikely. Next is the Fanconi anemia, which usually presents at the age of 6 to 8 years. Our child was 8 years old. Our child had triangular facies along with a beak-shaped nose. He also had skin manifestations like hyperpigmentation present around knuckles and the skin folds. He had cafe au lait spots. He had short stature, but there was no skeletal abnormalities noted. So most of the clinical features were going in the favor of Fanconi anemia. So we came to the diagnosis of inherited bone marrow failure syndrome, which is most likely to be a case of Fanconi anemia. Now I would like to ask audience, how will they confirm the diagnosis of Fanconi anemia?
What has to do next to confirm Fanconi's? Pediatricians बताओ, adults तो ये कम देखते हैं. Pediatric residents, third year residents, exam going, yeah. Can you specify what genetic studies, what gene would you like to look for? Can you do something else other than genetic studies, which can be done in-house? So learn something now and go read today.
So, in Fanconi anemia is a triad of bone marrow failure syndrome and congenital abnormalities and increased chromosomal breakage. So, to confirm the increased chromosomal fragility, we advised stress cytogenetics and whole exome sequencing. And to discuss further about these investigations, I would like to call Dr. Aditi ma'am from the Department of Genetics.
Unable to repair the DNA damage, thus forms distinctive chromosomal breakage patterns and rearrangements like gaps, breaks, radials, and exchange. At the end of the experiment, what is the important thing to note is that we calculate the combination of these events as break event in each metaphase. Briefly, what we do in the lab. So when the patient sample come to us in a heparin tube, we treat it with different concentrations of mitomycin C and study 50 metaphases each. Same we do in the control sample, and we arrange the control sample with same gender and about 5 years up and down of age to have the same metabolic rate. And as I said, in the end, we calculate the break event per cell. It was very difficult for me to show the calculations here because they are extremely lengthy and laborious, because at the end of the experiment, we study 300 metaphases. That's why the turnaround time is little more, which is 2 weeks. Until now, we have done 22 cases of chromosomal breakage. This is the kind of report we generate. When we say that the report is positive, we have some criteria. For example, the patient sample should have more than 4 breaks per cell. In this case, the patient had 4.22 breaks per cell, which is a positive number. Second criteria is the patient sample should be 3 times more the breaks per cell than the normal. In this case, it was 3.96. So the patient had more than 4, which is again positive. Looking at the report, this case clearly is suggestive of Fanconi's anemia. So why do we have to zoom in the genome? We are looking at the chromosomal level right now, which was suggestive of Fanconi's anemia. Now we want to look at the genome, the gene level for confirmatory diagnosis. We performed exome sequencing. About 20 genes are responsible for Fanconi's anemia, out of which 3 are the most common ones and are seen in about 80 to 90% of cases. So what is actually exome sequencing? We sequence only the coding regions of the genome. It provides comprehensive view of an individual's genetic makeup. It's a powerful tool for identifying genetic causes of a disease, and it's cost effective. When I say it's cost effective, I mean to say that it's relatively cheaper than doing whole exome sequencing. So this was the report that we got from whole exome sequencing that identified gene FANC-G, which is on the chromosome 9, had a frame shift mutation, which had deletion of bases A and T at the exon 10. Because the disease is inherited in an autosomal recessive inheritance pattern, I would strongly suggest to test the parents to see whether it's inherited or it's an accident, it's de novo. The report says likely pathogenic, meaning looking at the background, having other tests and the clinical features and the genetic report, this case is clearly suggestive of Fanconi. Yes, sir, we don't have it yet.
Have you monitored for more than 22 cases?
Sir, for 22 cases we did stress cytogenetics. Whole genome sequencing. We recently got permission, so we would get the machine very soon, sir. So in 2 months' time, we should be able to do it here.
The chairperson has already kind of
sanctioned us the machine, so we would buy it. So the whole package is coming to be about 2 to 3 crores.
There are lots of options in the market, so there's a lot of additional.
We should have a role, absolutely.
We are looking for an expert also.
Minimum outsourcing.
We should be able to do 17 months.
What should be the pattern of inheritance in Fanconi syndrome?
So it is autosomal recessive pattern, which
what is the autosomal recessive pattern?
Autosomal recessive pattern means that the parents would have the gene, but they would not have the disease because one allele is affected from the 2, but they have 25% chance of having an affected child because the child can inherit 2 wrong alleles.
What about the dominant?
Dominant, sir, 50% chance that the child will have the disease.
So what is this law called? What is this law called of inheritance?
Mendelian law of inheritance, sir.
All should tell me.
Yeah. Thank you so much.
Thank you, ma'am. So after the genetic report, we came to the final diagnosis of Fanconi anemia. To further discuss the management of Fanconi anemia, I would like to call Dr. Priyanka Soni ma'am, who is an assistant professor in the Department of Pediatric Hematology and Oncology.
Thank you, Dr. Shivani. Good morning, respected patrons, senior faculty members, colleagues and students. So I would begin by paying tribute to Dr. Guido Fanconi, who has first reported 3 cases in a family who had inherited disorder and who died of a disease resembling pernicious anemia. So Fanconi anemia is not just anemia, rather it is a genetically heterogeneous multi-system disease. It's a relatively rare disease with incidence of 2 per million in Western literature and 4 to 6 per million in Asian countries. Out of all the aplastic anemia diagnosed, about 20 to 30% cases are inherited depending on the age. In the pediatric age group, more cases are inherited as compared to the adults. So in our own Indian data, there is a study, largest series reported from AIMS of 1500 patients, where out of all aplastic anemia, 5% patients had inherited bone marrow failure syndromes. So Fanconi anemia is a DNA repair defect which comprises of bone marrow failure, physical abnormalities, and predisposition to cancers. So about 70% patient would present with some type of physical abnormalities in the form of abnormal facies, triangular face, V-shaped nose, skin abnormalities, skeletal defects, cardiac, renal and other abnormalities which they would present with. So we're coming to our patient, we have to follow a comprehensive approach in the management. For looking at the physical anomalies, it is important that we need to do an extensive multi-organ assessment, for which we have done ultrasound, echo, hearing and visual functions, which were all found to be normal. For aplastic anemia, we would assess the severity, look at other parameters, which I would discuss in further slides. They have high predisposition to cancer, specifically head and neck squamous cell carcinoma is most common, so we need to have a plan for cancer screening in these patients. And since we have an index case in the family now, it is important to provide genetic counseling for other members of the family too. So, since the patient has presented with a hemoglobin of 5.2 gram, it is important that we first stabilize the patient, for which we have given him the packed red cell transfusion. So for the benefit of the residents, I would just like to emphasize over here that whenever there is any transfusion dependent anemia, we should be careful that we should give them leukodepleted blood products. And these leukodepleted blood products, how does they help? They reduce the risk of aluminization, febrile non-hemolytic reactions, as well as decreases the risk of CMV transmission. And we are really thankful that we have a...
In our blood bank, we have the facility of providing leukodepleted RBC. That's very important. All the residents and doctors must know that we can provide as much leukodepleted blood as required.
So we are really thankful to Department of IHBT for providing us all good blood component therapy. Since the patient was not bleeding, we avoided giving platelet transfusions and no fever, so avoided antibiotics too. And we provided supportive care, including folate supplementation. So this is the immediate care. Now we have to provide a more definitive therapy, so for which we need to assess the severity of aplastic anemia, which is done by modified Kamita criteria, which are based on bone marrow cellularity and blood indices. So again, I would like to emphasize over here that assessing bone marrow cellularity is very important. So it is very important that whenever we do a bone marrow examination, we do an adequate bone marrow biopsy. A 2 centimeter piece is very, very important, so that, because this is the only accurate method to assess the cellularity. So based on these parameters of the patient, he was classified as having severe aplastic anemia. So inherited bone marrow failure syndrome with severe aplastic anemia, the only curative therapy for this bone marrow failure is hematopoietic stem cell transplant. There are other indications in Fanconi anemia for transplant, which are if the patient presents with myelodysplastic syndrome or acute myeloid leukemia, for which we have advised the family to undergo a high resolution HLA typing from the family donors. But at this point, we must remember that hematopoietic stem cell transplant is only going to cure the bone marrow failure. It is not going to change the risk of cancer, rather it would increase the risk of late malignancies. So we have to weigh the benefit and then we have to counsel the family accordingly. We are fortunate that we have a state-of-art BMT facility at our center, and where we can do both benign and malignant transplants, and we have done more than 50 transplants at this center. But not all the centers are so well equipped. So we have to have a non-transplant approach. Also, the family needs to have some time to decide for such a big therapy and approach, and where the benefit may sometimes outweigh risk. So they need time. So in the meantime, we need to stabilize the patient by giving minimal blood transfusion to maintain an adequate level of hemoglobin, not too high, and minimal platelet transfusion, because there is risk of iron overload. And if there have been more than 10 transfusions, then we must go for chelation therapy as well. Then another important drug which we use here, which is used for ages, is androgen therapy. So brief about how does it act. So if we see the androgens, They bind to steroid receptors, include and induce a higher expression of the enzyme telomerase, which leads to stabilization of chromosomes and restoration of hematopoiesis. This is one mechanism. They also synergize with erythropoietin and enhance the erythropoiesis. They act on phagocytes of innate immunity and they decrease platelet clearance. They also stabilize cell membrane, red cell membrane, preventing hemolysis and RBC clearance. So they have pleiotropic effect on hematopoietic stem cell. But actually, how does it help? So there has been a large study from Germany. It's a 30-year study comprising about 70 patients, and it showed a response rate of 68%. Another newer study is published by European Society of Blood and Bone Marrow Transplant, which is a multi-centered studies and includes all EBMT centers, including some of the Asian centers, where 274 patients were assessed, and out of which 82 patients were of inherited bone marrow failure syndrome. So if we see, this is a survival which I am showing only for inherited bone marrow failure syndrome. So if we see, the failure-free survival is 14%. So the therapy is going to act, but it is only a bridge therapy. We have to go for a definitive therapy. So overall survival is 78%. This overall survival has been achieved by undergoing a hematopoietic stem cell transplant. So in our patient, we started him on danazole at the dose of 5 mg per kg in 2 divided doses, and apart from folic acid supplementation, we intend to follow him up with CBC every 4 to 6 weeks, and it is also important to do bone marrow studies 3 monthly. This is because these patients can develop any new cytogenetic abnormalities or leukemias at any point of time. Since the family is still deciding for transplant, we have been counseling them for HLA typing and hematopoietic stem cell transplant. So if we see the effect after starting the danazole, we have just one follow-up with the patient, and it has some effect on improving the absolute neutrophil count and platelet count, although it had minor effect on hemoglobin. So we can say that the patient has achieved some partial response with the therapy. We need to be aware of the potential side effects of the danazole, which could be virilization, hepatotoxicity, hepatoma, hyperlipidemia, psychiatric and behavioral effects, and we need to monitor the patient.
The hemoglobin come in, so 6 gram January.
Yes, sir.
What about April?
Sir, actually the patient is not following up with regularly, so we have advised him to take transfusion if the hemoglobin goes below 8, but their follow-up is a bit irregular.
When he came at 6 gram, that's right?
Yes, sir.
When he came at 6 gram in January, what did you do?
So we advised him to get a transfusion done, but he has refused for the same. So we continued with the danazole.
Why should he refuse? He's not agreeing for bone marrow transplant also.
He feels that the child is clinically well right now, so he's not understanding. So probably, sir, he's in the denial phase, not accepting that the child would require this therapy at some point of time.
The danazole is very safe. We obstetrician gynecologists use it regularly in necrosis in other patients. Used to. Now, of course, not a very it's good there. So, patient delay is
Another important thing is there is very high risk of cancer. So as I said, head and neck cancer is 500 to 700 fold higher risk than general population, and esophageal cancer 2000 fold higher than the general population. So we need to make a plan for annual screening of head and neck cancers, skin cancers, doing an ultrasound annually, and after a certain age, maybe 16 to 20 years, we need to start evaluating for esophageal, breast and ovarian cancers. Genetic counseling is based on the inheritance pattern. So most of the Fanconi anemias are autosomal recessive, but there are 2 subtypes. One is X-linked recessive and one is autosomal dominant. So once we have a genetic diagnosis, we can counsel the patient accordingly. This is a very important point, that an asymptomatic individual could be affected. So it is very important that we need to emphasize that the other family members, other siblings should have cytogenetic testing or genetic testing for their diagnosis. Heterozygous carriers also have increased risk of cancer, although they are less likely to have bone marrow failure. So we can also offer prenatal diagnostics for a certain subset of patients.
क्या offer करोगे इसमें prenatal?
Sir, if we can, in the next pregnancy, if there is a pregnancy, we can do an amniocentesis and look for if there is a homozygous mutation. If there is a homozygous mutation in case of autosomal recessive, then we may tell them that they may not continue the pregnancy. Newer researches are ongoing. Gene therapy is on the way, but it is only available for Fanconi A subtype, and it can produce results only in early stages of marrow failure.
What type of gene therapy is available for some patient?
So in this case, sir, they are collecting the hematopoietic stem cells from the patient who is affected, and they are re-engineering the cells and then transplanting it back. So this can be only done in a small, in very few cases where the anemia is only moderate, where the stem cell reserve is still preserved. That is why it is not being successful, because usually the patients are diagnosed.
What will be the gene therapy you expect?
To help only in bone marrow failure, not in general.
कौन सी gene therapy? Gene editing होगी,
gene editing.
क्या नाम है उसका?
Sir, I am not sure.
What is the CRISPR technology? And we are going to have MOE today itself. Today's thalassemia day. We are going to have that.
There are other small. So there are other small molecular interventions which are ongoing, because we want to know that whether both anemia and cancer could be controlled, not just bone marrow failure. So other researches is all ongoing. So it is very important to identify such children and do timely intervention. Follow-up is very important, because many genetic problems will evolve with time. So it is very important to have an adequate follow-up. So with this, to conclude this, I would like to invite Dr. Shivani again.
Thank you, ma'am. So take-home message from this presentation is that not all the anemias are nutritional anemias. If any child coming to the OPD is not responding to the conventional therapy, a multidisciplinary approach and a complete clinical evaluation is very important, and genetic workup, if required, has to be done, because the timely diagnosis and management will lead to a healthy life for the child. Thank you.